Okay, so like I say, I can't even remember what is today's topic. So I'll be just as surprised as you are, but I hope it's a good one. Let's see. Can you guys see okay over there? Can you pull it a bit straight? Is that all right? Hope that's all right. I think that's the best. Okay. All right. All right, good. So this is our patient for today. All right. 57-year-old man with chest pressure and diaphoresis. Okay. So as you all know, when we analyze an ECG, which we're going to do on the next slide, all right? We analyze the axis, then we analyze the rhythm, we analyze the rate, and then we analyze each zone, all right? So that's what we're going to do. Okay, now I remember which one this is. But even before that, let's say you were sitting in your car, all right? And you're the only doctor wherever you are, all right? And this is what the nursing staff phones you with. 57-year-old man with chest pressure and diaphoresis. What are you already worried about? Especially diaphoresis. Am I? Yeah, especially with diaphoresis. Okay, age, 57 years old. All right, so in that age range of ischemia. Okay, chest pressure rather than chest pain. Okay, so what we normally taught in medical school is that you're supposed to have central chest pain radiating to the jaw, radiating to the arm. Very uncommon, actually. You don't normally see that. Okay, in fact, when you see that, I actually get worried. It may not be an MI. You know, it may be something else. No, it's just that's how they teach it to us because that's what it's supposed to be because that's the distribution of the phrenic nerve. But the truth is that we often don't get that. There's different zones depending on where your MI may be taking place. So you may have right shoulder pain. You may have epigastric pain. You may have pain that's just in the jaw, dental pain. In fact, what they suggest is that if you have any unexplained pain above the pelvis, do an ECG. That includes headaches. All right. So, you know, there's lots of instances where patients have been mistreated with pain only to find out later that they're actually having cardiac ischemia. It doesn't necessarily mean an MI, unstable anginas, things like that as well, right? Or anginal attacks and that. So there's no harm. I mean, if you've got an obvious cause, if you've got a guy there now, I mean, he's hurt his shoulder in an accident. I'm not saying do an ECG for him. First you do your X-ray and then you see. But somebody just walks in with unexplained pain, your X-rays are clear, everything is okay, but this person is insisting they've got severe pain with some odd sensation. There's no harm. Do an ECG and you'll be amazed at what you find. Okay, all right. So let's just go on to that. All right. So a few of you have been here a little while. So who wants to tell me about the axis? Does everybody remember how we work it out? Or you can work it out in whatever way you want. But what's our axis looking like over here? Should we draw it out? All right, let's draw it out. All right. So let's put our little there. So we've either got normal, left, extreme right, or right. Okay. With lead 1 and lead AVF sitting over there. So which way is lead 1 pointing? Up or down? More positive. Agreed? Or not really? Okay. Lead 1 is pointing more upwards. Agreed. So we say that if lead 1 is here, that means electricity is moving towards it. I see a lot of blank faces. This is supposed to be the easiest part. Okay. So it's either here or here. All right. So we know for sure that we don't have an extreme right axis and we don't have a right axis. All right. So in order to determine it, we need to look at lead AVF, all right, which is here at the bottom. It looks at the body from that side. So which way is lead AVF pointing? A bit biphasic actually. All right, so you can see some of it is down, some of it is up. So that means when a lead sees something as biphasic, it means that it's perpendicular. So in other words, it's seeing electricity coming towards it for a little while and seeing electricity going away from it for a little while. So as electricity is coming towards it, positive. As electricity is going away from it, negative. In this case, what are we seeing? It's seeing electricity going away from it initially, isn't it? And then coming more towards it a little bit. So we're actually seeing something more in this area. All right. So we've got sort of a left axis deviation. All right. So if we say it's a left axis, even though it's a physiological left axis, but what does that tell us? That either something's happened on the right-hand side. So the right-hand side is damaged. So that's why electricity is moving to the left-hand side, or the left-hand side has become larger. Okay, so that's why we start off with axis. Okay, all right, let's have a look at our rhythm. Here is a good one where we can see. So how do our P waves look over here in lead V3? Normal, abnormal? Yeah, relatively normal. Okay. And then we said our normal spacing for our PR interval is supposed to be 2 to 4 blocks. All right. So in this one, it's 1, 2, 3, 4, 5. So a bit elongated. All right. So what do we call an elongated PR interval? It's called a first degree heart block. All right. So first degree heart blocks are quite common. In the setting of pathology, they can be significant. Outside the setting of pathology, they can be insignificant as well, right? Just a regular finding. But we know we don't have just a normal rhythm, okay? Then what's the next part of rhythm? We check if our QRS complexes are narrow or wide. So what do you guys think? Narrow, wide? Quite narrow, actually. These are not really wide complexes. This may confuse you, but this is actually the ST segment, all right? But the actual QRS complex is narrow, okay? Does a QRS follow every P wave? Yes, it does. And are they relatively regular? They are, all right? So except for the first degree heart block, it's relatively normal. And then our rate here, let's work it out. 1, 2, 3, 4, 5, about 60 beats per minute. Okay, but now let's get into the juicy stuff. So who would like to start with the zone somewhere? Shashin, I know you're just back from leave, so you can relax over there, don't worry. So what zones do we know? Does anybody remember? Okay, let's start. The inferior zone is which 3 leads? AVF, lead 3, and lead 2. All right, so lead 2, 3, and AVF, look at the bottom side of the heart. What do we notice on leads 2, 3, and AVF? Specifically here. So this is our QRS complex, all right? In other words, this is the QRS. And then as soon as it changes, that is the ST segment, all right? So these are ST segments, all right? Just for example, like here, this is a QRS, and then as soon as it changes, that becomes your ST segment, all right? So are these ST segments elevated, depressed, normal? What do you think? In other words, are they above the static line, or are they below there? What do you think? Above, very good. So if it's above, it's an ST elevation. All right, so ST segment elevation. All right. So ST elevations are significant for ischemia. Anything else that you can think of? Okay, let's leave it at ischemia for now. All right. So everybody's coffee hasn't kicked in today, so I won't stress it out too much. All right. So let's concentrate on ischemia. All right. So what happens is that basically, when this ischemic pattern starts happening, the channels, all right, the electrolyte channels that are normally there on your cell membrane are now damaged. So the ability of the body to repolarize normally is affected, all right? So the actual physiology, pathophysiology behind it is quite interesting. It's a whole lecture on its own, how the sodium, potassium, calcium channels all change around and why this prevents electricity from returning back to zero, why it stays up and things like that. But it's a whole lecture on its own. I don't want to get into it now. But if you have time, go and read on it. It makes a bit of sense as to what they're talking about, right? So what we see is that we've got ST elevations in leads 2, 3, and AVF, which implies that the inferior part of the heart has been affected. Now, is this definitely an ischemia? No. We have to make sure that there's something called reciprocal changes. So what are reciprocal changes? Reciprocal changes means that if he's lead AVF and I'm on the opposite side, lead AVL, for example, if he sees something, I must see the opposite. Agreed? To confirm that it's happening, all right? So in other words, if he sees this bottle falling towards him, I should see it falling away from me. That's called a reciprocal change, all right? So in his case, if he's lead AVF, he sees the elevation, all right? Moving towards him, the opposite side of the heart, all right? So let's look at the opposite side of the heart. So for example, V1, V2, let's just hide this one, sorry. So V1 and V2, which are the septal leads, what do we see? Are these ST elevations or depressions? Very good. So those are ST depressions. All right. Then we look at the anterior part of the heart, V3, V4. What do we notice more here than anywhere else? So if that's the normal 0 line, all right? So you look at this. This is your ST segment, okay? Is it above or below? Below. So it's an ST depression. Very good. Then we come to V5 and V6. What do we notice there? If this is the 0 line, in this case, the ST segments are very good. They're elevated. So that's telling us maybe something's happening on the lateral side of the heart, okay? Then we come to leads 1 and AVR, which are your high lateral leads. And do we see that they are elevated or depressed? Very good. So we've got a lot of reciprocal changes going on. And then the last lead is AVR. And in AVR, we also see a bit of a depression. Okay. So if you were sitting there now, 2 o'clock in the morning, you've got to convince your physician to come in. What parts of the heart are you going to tell the physician are involved? Inferior, very good. And the lateral side. Okay. And how are you going to treat this patient? What are you going to do? Is Dr. Makanka or Dr. Mbele? What are you going to do? Dr. Karwa, what are you going to do? Right? Because your job is not to phone people. Okay. Remember that when you work in an emergency department, your job is to stabilize. So how are you going to stabilize this patient? Otherwise, what are you going to do for this patient? What are you going to give them? Give them a slap on the back and say, I hope it works out. Hope the physician comes quickly. So yeah, develop MOPD, check blood result. So what are you going to do? In other words, how are you going to treat this patient now in your emergency department? That's the thing. So the first thing is the patient is in pain, right? So how are you going to treat the pain? What drug are you going to give? Panado? No. What are you going to give? Are you going to give pethidine? Morphine, all right. Pethidine affects cardiac contractility, all right? Just remember that. So we don't give pethidine, we give morphine, all right? Now, morphine as well, when you've got a confirmed ST elevation, in what we have here, ST elevated MI, then we start off at 5 milligrams, all right? We give 5 milligrams and we increase it by 1 milligram at a time, depending on how the patient is feeling. So let's say, for example, I was your patient. You gave me 5 milligrams, I'm okay. After about 5 or 10 minutes, I'm getting a bit of pain again. You'd give me another milligram. Again, I give another milligram. There's 2 reasons for that. Number one, morphine is an opiate, so it's a central, what you call it, block of pain. Okay, so it tells the brain there's no pain. That's why morphine works. All right. Second thing is, what is happening to this patient? You are lying on this bed. All right. He's a 57-year-old man. Let's assume he's got kids, grandkids. He's working, he's close to retirement, maybe he hasn't reached all his financial goals, whatever it may be. Now I'm sitting over here and what are the doctors talking about? They're talking about a heart attack. Now I'm a lay person. What does heart attack equal? Equals death. So what's happening to my heart? It's pumping. It's pumping hard. How am I breathing? I'm breathing hard because this is it. I'm going. They're telling me I'm having a heart attack. They told me 20 years ago to stop smoking. I didn't listen. They told me don't have McDonald's 3 times a week. I didn't listen. But now I have to pay the consequences. But I've got my family at home. I've got everybody at home. But I'm dying, right? So what's the worst thing for my heart? Because it's not receiving enough blood. What's the worst thing that can happen to me? Right? Beats harder. It's going faster. So in order for my heart to beat faster, what do I need more of? Blood. And what am I not getting? Blood, because there's a blockage. So what am I doing by having all of these emotions and adrenaline pumping and being anxious and all? I'm actually making my condition worse. All right. So what morphine does as well, morphine goes in, makes your patient nice and high. So your patient chills out. That's a simple way of putting it. Your patient chills out. Once your patient chills out, their heart relaxes. Okay. Look at anybody who's on morphine. They're not worried. They couldn't care less. Agreed. So what's happening is you decrease the amount of metabolic load of the heart. All right. So the heart suddenly calms down, relaxes, and your patient feels a lot better. All right. What else are you going to try and give them? Now we know there's a blockage. Yes, you're going to give them oxygen. You're going to try and keep the oxygen concentration as high as possible. So you're going to put them on a face mask, 40%. Try and keep their sats above 96, 97, 98. Anything else you're going to give them? We know they've got a clot. All right. Sorry. Okay. So you want to give them TNT. All right. I'm guessing. No, that's not a bad answer, but we'll get to why it's a problem for this patient a little while later. All right. But you would think of TNT most of the time. All right. Anything else you could give them? A little tablet to chew, yeah, aspirin. Anything else you could give them? Yes, you can give them beta blockers. You can give them calcium channel blockers because this also decreases the metabolic load of the heart. And anything else you can give them?
Clopidogrel.
Very good, clopidogrel. Okay.
And streptokinase.
Yes, you can give them streptokinase, that's for sure. Okay, so in other words, you can thrombolize them. Okay. So generally, thrombolysis won't take place in the emergency department unless your patient is dying then and there, right? But these are the things that you would think about. But let's get thinking about what the doctor was talking about, which was TNT, all right? In this particular one. All right, sorry, let me just move on to the next one. All right. So we're gonna talk about TNT in a little while, okay? But let's get on to what happened with this patient, okay? So we had a sinus rhythm, all right? The reason why they call it a sinus rhythm is because your atrium is functioning normally, all right? We found the first degree AV block, agreed, rate of about 62, acute inferolateral MI, all right? With possible right ventricular MI. Now the question is, why are they saying it's a right ventricular MI? So this is just a rule of thumb, all right? So it's a general rule. When you've got ST elevations in lead 2 and lead 3, all right? If the ST elevation in lead 3 is higher than lead 2, then we say it's not just the inferior part, it's extending onto the right part as well, okay? Because lead 3 looks more at the right-hand side. Okay, so how are you going to confirm that? Any idea if the right-hand side is affected? Okay, we'll get to it just now, right? So ST segment elevation is present in the inferior and lateral leads with reciprocal ST segment leads 1, AVL, V1, and V3. With the magnitude of ST elevation, lead 3 exceeds that in lead 2, right ventricular infarction is likely. Okay. A more definitive diagnosis of right ventricular MI can be made using right-sided precordial leads. So have any of you guys ever done that before? Done right-sided precordial leads? Okay. We're going to get onto it just now, right? Because what we want to do is we want to see the right side of the heart. So you do something called a 15 lead or an 18 lead ECG. All right, do you know where to find that machine? Do you know where the 18 lead ECG? Seriously, you don't know where it sits. Then how are you checking? Eh? There's no such thing, all right? There's no such thing as a 15 or 18 lead ECG. You still use your normal 12 lead ECG, right? But your 12 lead ECG is not what you call it, stuck in just doing these leads, all right? So what we're going to do now is we're going to have a little look at a video that's going to show us how to do the right precordial leads, okay? Just so that
it burns a few more electrodes, but you can take a full right-sided ECG by doing nothing more than mirroring your electrodes down the patient's right side. And then all you would do is reverse the actual electrode placement. So you would just take V1 goes where V2 was, V2 where V1 goes, V3, V4, V5, etc. Now these ECGs don't really take a lot of effort to learn how to interpret, but just as a quick pointer, you want to make sure that you pay particular attention to V3, V4, and V5. Those can really show you that right-sided ventricle, and that right ventricle can be your problem in an inferior wall MI because those patients are preload dependent. So if you want to start practicing these on your fairly normal patients to start getting a good idea what a normal ECG looks like from this side, you'll have a good baseline for when something's going wrong, and it'll give you an idea of how you want to proceed.
Okay, so basically all that you're doing is you're taking your leads from this side and you're putting them onto the other side, all right? The reason being now, when you put it on this side, you're concentrating on looking at that left ventricle, all right? When you move it onto the other side, you're concentrating on looking at the right ventricle. So what would you expect to see? You would expect to see what you would see for a left-sided MI. You'd expect to see it on the other side, all right? The most important thing is to label that ECG properly. So what we do is normally we write the 18 lead ECG, where you see V3, V4, V5, V6. Now we put R next to that. That's it. So people know that it's that side. Because if you don't do that, somebody assumes, no, this is a left-sided MI, whereas in the meantime, it's a right-sided MI. And we'll talk about why that's so important just now, right? Just want to see if I've got one here, right? So our normal treatment plan, O2, morphine, dispirin, clopidogrel, and then we put TNT under the tongue, and the patient dies very quickly. Any idea why this patient is going to die with TNT? I have to teach you guys this because patients have died, all right? Okay, so it's very important that we know how the right side of the heart functions. Okay, so let's have a look about nitrates, and right-sided ischemia. Okay, so what we normally have if we have a right ventricle, all right. So let's take our patient in this case. Our patient has a right ventricular MI. That right ventricle already has decreased output due to damage. All right, so we've got ischemia that's happening over there. This heart is not able to produce properly, all right? So what's happening there? The right ventricle can't pump properly. So how much of blood is going through the lungs into the left ventricle? Less. Agreed. It can't pump that hard. So it's not getting enough into the left side. Okay. So what happens then? How much of blood reaches the left ventricle? Less. How much can it expand? Less. So remember Starling's law? You have to stretch the ventricle to get it to contract. So if you can't stretch it that much, can it contract as hard? No. All right. So already from that right ventricle, you're getting less blood coming to the left ventricle. It can't pump. All right. So what happens to your blood pressures? They decrease. Okay. What do nitrates cause? Vasodilation. All right. So when they cause vasodilation, all of these blood vessels throughout the body start to dilate. When you dilate a tube, what happens to the pressure within it? It drops. Okay. So what happens? Even the inferior vena cava starts to dilate because you've given those nitrates. Okay. So normally what happens is that when we breathe in, you create negative pressure within the thorax, right? And that actually sucks up blood from the IVC into the right ventricle. But now you've got a dilated right ventricle. I mean, you've got a dilated IVC. So when you breathe in, you've got this decreased pressure. How much of blood can now reach the right ventricle? Less, isn't it? So now your right ventricle is getting even less blood to itself. So how much is it stretching? Less. So when it stretches less, how much can it push through? Less. So how much its output decreases. So what happens? It has decreased output now due to the nitrates and the damage. So how much blood goes through to the left ventricle the next beat? Less. So how much gets back to the IVC? Less. So how much gets drawn back into the right ventricle? Less. So how much goes back to the left? Less. Do you see how your patient is spiraling downwards, 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 downwards? All because you put a little tablet under their tongue. Okay. The reason why I say this, normally when we see chest pain, we run with the TNT. Agreed? We're holding two boxes in our hands to make sure in case one is empty, we'll make sure the patient gets this. Do you see how important it is to do your ECG before you give nitrates? Okay. Left-sided, no problem. Give your nitrates, it's no problem. It will make life a lot easier. But once you give nitrates to the right-sided ventricle or to the right-sided MI, inferior MI, suspected right-sided MI, you've killed your patient because now they can't get enough blood into their system to be able to sustain themselves. So they just start going down and down and down. And normally what happens when these patients do arrive, their BPs are already low, right? Because they're already struggling. Their right ventricle can't push out in any case. So they already have low BPs. So you're going to just keep on pushing them lower and lower. So the way that you treat these patients, you give them everything else. You just don't give them the nitrates, okay? And very often these patients actually require large amounts of fluid to actually sustain themselves. Even if they are a bit fluid overloaded, we still give them fluid because at least you're stretching that right ventricle. Whatever capacity it still has, but at least it can still push through and keep the patient alive. The only thing that's going to save this patient is thrombolysis, okay? So thrombolysis, streptokinase, alteplase, whatever you've got available to you, then you can use to thrombolize your patient, okay? In these cases, I must be honest, most of the patients who pitch up with right-sided ischemia do require PCI at some point, all right? Percutaneous coronary insufflation, balloon stenting, all right? To put it simply, all right? Not necessarily, but there's a lot of them that do require it as well, okay? So just remember that. Don't run with TNT every time you have a patient with chest pain where you suspect an MI. First thing to myself, is this a right-sided MI? Because if it is a right-sided MI, my nitrates are going to kill this patient. Okay, so that's why it's so important. All right. I don't know if they're testing or they really. Okay, so that's the end of this one. All right. Now, I'd love to show you how I don't know why I didn't put it on. I was sure I put it on here. But basically, let me just show you one other thing. So what happens is when you do your right-sided MI, all right, or you want to check for a right-sided MI, and you move all of these across, what you would see is instead of ST depressions over here, you would just see ST elevations. That's very minor, but they are still there. The reason why they're not as pronounced as, let's say, this is simply because the right ventricle is not as thick walled. So it doesn't produce as much electricity. All right, so you still see all of that. Okay. I don't know if anybody has any questions or anything that you want to know. It was more just to concentrate on the nitrates besides working out the ECG, but I just wanted to show you all the point of it, okay? Because sometimes we do things automatically, but not realizing that we're actually causing a problem, you know? It's like giving fluids to a patient in CCF. You don't just run and give fluids to everybody. You have to first look at their fluid status. Now, it sounds simple, but it's something we all know. Your patient is edematous, we don't go and give them fluids. But this is equivalent to doing that, you know what I mean? Just automatically, you know? So we're not robots, you know, that a robot can do. You know, you tell a robot, there's a patient with chest pain, program what they must give, and they'll give it. We're not robots. That's why we studied for all these years, to know all these things, okay? But are there any questions, anything I want to know, even from the people on Zoom? Make sense? Okay. I know ECGs are difficult, but I always tell, especially for the students and for you guys as interns, your job is not necessarily to know every diagnosis, but at least to be able to tell what's normal from abnormal. So even if you know this is abnormal, I'm happy, because it means you'll go and ask somebody. So if you get an abnormal ECG, you bring it to Dr. Gemraj, you bring it to me. It doesn't mean you must know every single ECG that's out there. Right? You'll be covering relatively simple ones. So these ones, you should kind of get an idea in a few weeks' time. You should become more used to reading them and things like that. And hopefully as the year goes on, we'll do some more difficult ones. But these are still relatively easy ECGs, okay? All right, if everybody's okay and everybody was happy with that, and unfortunately it means the rest of us have to get to work. Whoever's on Zoom can get back to relaxing or whatever they do, I don't know. Okay, no problem. Then on Wednesday, we'll cover another ultrasound topic and then we'll see from there. Okay, but just so long as you all enjoyed it. Okay, guys, and then, yeah, we'll end it over there. Okay.